enthusiastic, so it makes my job really easy. Yeah. So I work at SUNY Downstate. That's in Brooklyn. Anybody here from Brooklyn? Right, Brooklyn in the house, right? Okay. Okay, so hold on, guys. I got you riled up. I'm an emergency medicine doctor, and I work at Kings County Hospital and also at SUNY Downstate. My specialty is emergency medicine, like I said, but I'm also a self-specialized in pediatric emergency medicine. So I've been doing this job for maybe about 10, 12 years right now. And I was invited by Dr. Saad to discuss about emergency medicine to you. And specifically, I'll be talking about a little bit about what emergency medicine is like, a little bit about our future, and I'm going to give you a case presentation. And it'll be a little bit obvious at the end of the case presentation when I'm going to get the point across. So, when we talk about emergency medicine, it's a specialty on time. If you think about it, medicine has traditionally been broken down into organ systems or patient populations. Meaning, organ system, you can go see a doctor that's a cardiologist, or you can see a doctor who is a gastroenterologist, or something like the brain, like a neurologist or a neurosurgeon. Or you can take care of certain patient groups, like a pregnant lady or kids. But in emergency medicine, it's a little different from that. Our specialty is based on time, meaning when we have a patient, we have to see what are life-threatening events or anything that potentially has high morbidity and high mortality. That's our bread and butter. That's what we do for our patients. So what we do in this particular profession, we take care of everybody. So we take care from the very young or to the very old. And we also take care of patients from all social strata, meaning from the lowest, that could be maybe the homeless person, to the highest, like a CEO or corporation. We see everybody, we take care of everybody. So these are some of my colleagues that I work with in my hospital. This particular guy, I'm really proud about, right? He went to become Batman. So how many of you actually have a colleague that actually became a superhero? We're pretty proud about that. He became Batman. Okay, in terms of emergency medicine, I'm going to give you a little bit of history about this. Our profession is a relatively young profession, and in 1961, a bunch of docs in Alexandria noticed that docs who work in the ER tend to be of two different varieties, or two different flavors, so to speak. One group of docs are, say, like a surgeon or an internalist who work in the ER. They moonlight a little bit and take care of patients. But part of the problem is, if you have, say, like a pediatrician working in the ER, and you have an older person coming in clutching their chest, complaining about chest pain, and has a heart attack, the last person you really want to take care of that patient is a pediatrician, right? Right? Then usually the young patient. So in 1961, there's a bunch of docs that kind of figure our profession, emergency medicine, needs to have like its own particular group and its own particular way of thinking and doing things. So they were saying, let's push for docs that are really good at emergencies, meaning we can take care of everybody with all the problems, take care of things with high morbidity and high mortality. So at that point, they start pushing for more of an organization, more docs being trained in emergency medicine. And so that's development of what we call the Alexandria Plan. And over the course of their efforts and their, foresight, they developed the American College of Emergency Physicians, which is like a whole group of doctors that got together, trained based on this particular theory. And during about that time, residency or medical training has started to change at that point. Meaning, instead of going to, say, internal medicine and go to surgery, doctors or medical students can actually decide, I want to go into a field of emergency medicine. I want to be trained in taking care of acutely sick and critical patients. So at that point, emergency medicine started to take off. And around 1973, the American Medical Society recognized us as a bunch of docs with a particular set of skills where we can take care of patients. And over the course of time, through 1979, the American Boards of Medical Society recognized us as a true specialty, meaning we're a particular specialty with their own unique needs, skills, and insights to taking care of particular groups of patients. And finally, in 1989, we're fully recognized as a full specialty, akin to like the surgeons, the pediatricians, and the OBGYN doctors. So in terms of our history, we're a relatively young specialty, but over the course of like a short period of time, over like 30, 40 years, we've gone from a change in paradigm, how we think about how to take care of patients in the ER. So what's our future right now? So our future is kind of dependent not on emergency medicine, but what we're going to do to take care of other groups of people, meaning fellowship training, meaning pediatric emergency medicine, disaster, toxicology, sports medicine, and hyperbaric type of training. This is additional training on top of the emergency medicine training that we receive. But if you all pay attention to the news, you notice that emergency medicine it is an important issue in medicine in general, meaning some people consider us the safety net for healthcare, for our society, and we've kind of embraced that. But because of this role that we play, we have to take care of everybody, but we can only take care of so many people so many times. It's like this big push that we want to take care of everybody, but we just don't have the resources. The resources we don't have, meaning of manpower, in terms of hospital, in terms of overcrowding, wait times. These become big issues for us. People without insurance, the uninsured, these are becoming more and more issues. If you kind of follow the political situation going on, these are hot button issues with us. And even within our own society, meaning American College of Emergency Physicians, we've kind of developed political action groups, committees to kind of go to Washington and be proponents for us, doctors, but also be proponents for everybody, I mean society, because we've kind of embraced this role that we've taken upon ourselves. So what I'm going to do, I'm just going to give you a case presentation. I'll go through a bunch of different scenarios or things you should think about. And at the end, I'm going to kind of bring home like what the heart of emergency medicine is like. So we have a couple that's driving back home. The driver swerves to avoid hitting the dog, right? So when the driver swerves, the car rolled over. So something happened, something bad happened. So we have to take care of this couple. So vital signs. The first one is for the driver. His blood pressure is 170/80. His heart rate of 50. His respiration is 4. And the passenger, the blood pressure is 85/40. Heart rate of 120, and respiration rate of 16. If you kind of look at that, you kind of glean from that, at least from the driver's abnormal vital signs. One thing that pops up at you right now, at least for me, is, well, first of all, the blood pressure is a little high. It's 170/80. You know, they say normal is like 120/80. So this is a little bit on the high side. The heart rate is 50. Normal should be right anywhere from 60 to 100. And the respiration is 4. Normal is about 12. So this tells me this driver is sick. He's ill. Something's going on. And okay, if you look at the vital signs for this passenger, the blood pressure is 85/40. The patient's in shock. That's what we emergency medicine say. The patient's going into shock. The patient's hypotensive. The heart rate's 120. Okay, that tells us the patient is tachycardia. I mean, the heart rate's going really, really fast right now. Something potentially bad's happening, but the respiration rate is 16, so that's normal. So, looking at these vital signs, something potentially bad's happening to both the driver and the passenger. So we do what we call a history and physical, meaning we ask the patient or ask EMS what they saw, what exactly happened, if they can give us information. And the physical, exactly what it sounds, to co-examine the patient. But emergency medicine docs are creatures of focusing on things of high threats, of things of life-threatening events and things with high morbidity, high mortality. So when we do our H&P, the driver said, well, we noticed that he has no breath sounds. And we do a quick history and physical. The passenger says, my leg hurts. So you think about it, okay, emergency medicine doctor, if someone's not breathing, what do you think you want to do? Give oxygen. But even before you give oxygen, if the patient's not breathing, you've got to get them breathing, right? If they can't take the breath in, you've got to help them out. And then